All right, let's rock and roll. I guess I'm going to use this. They didn't have the Britney Spears headset, so I'm stuck with this thing. That's the Britney Spears headset or the Time Life books. Thank you for calling Time Life Books. Okay, this is going to be really awkward for me, so I don't know what else to do. Okay, all right. So we're going to try to cover basically a semester's worth of crap in 2 days. So saddle up. We're getting ready to rock and roll. And then we have, when is your exam in here? A week from today. So it sounds like I'm going to have the bulk of that exam. because I have 2 days of this and a day of headache on 3 weeks worth of crap. Dang. All right. So we'll have to figure something out to where this is actually doable. Low ball, what? Easy. Oh, easy. Okay, softball questions. Okay. All right. So sportsy stuff. Okay. So from the learning objective standpoint, so basically because there's so much stuff that goes into this, really what I did actually yesterday is I went back through and I tried to figure out what do I really want you guys to have as far as a baseline knowledge of pain management and pain assessment. So these learning objectives aren't just, slide filler. Actually, if you can walk through these and study based off these learning objectives, you should be in pretty good shape. Okay. So our obvious epidemiology slide. Why is it a big deal? In my personal opinion, I think that this is one of the more important lectures that you guys could get in therapeutics, and not because I'm doing it, but because it impacts so many people in the US. I mean, if you think about like diabetes and heart disease and all the other stuff, even combined, doesn't match the number of people in the US that report chronic pain. And if you throw on top of that the fuel of opioid and the opioid epidemic we're dealing with and the overdose rates, this is an area that's really prime for pharmacist involvement. So that's why I think it's so important. When we talk about pain, and not to get too spiritual and all of this stuff, but really think about pain that you guys have had in the past, because everybody has had pain at one point in time or another. Think about the pain that you've had, okay? And then in the same context, think about the suffering that you experienced associated with that pain, okay? And I think a lot of times we get those two terms mixed up, or that we use them interchangeably, okay? Pain is the actual physiologic mechanism of protecting your tissues, but suffering is the total package, all right? And so when a bunch of really smart people sat down and tried to define what is actually pain, can it be limited to something that we can put our finger on, or that we can image, or that we can touch? Obviously, it's not, right? It's not, because you can have pain and we can't find the cause of it. Okay, and so the piece of this that goes into suffering is really where the definition came from the International Association for the Study of Pain. And basically that is that it is a sensory and an emotional process. Okay, sensory and emotional. And it can be in the face of real or potential tissue damage. So we don't have to actually see tissue damage occurring or organ damage, okay? It can even be potential damage. And so that's where the definition really that's currently accepted by all the big organizations came from. Now, there was a nurse who has probably done more for the clinical care of patients in pain than anybody else over the last 20 years or so, and her definition is really simple. Pain is what the patient says it is, right? Because how can we test it? Supposedly you have sympathetic response and your heart rate goes up and your blood pressure goes up and your respiratory rate goes up. However, that's not always the case. And so we have to depend on the patient to tell us what they're actually experiencing. And so pain really is a total subjective experience. So it is what the patient tells us it is. Now, we've also gotten ourselves into a little bit of trouble around that over the last 10 years or so, right? Because all I have to do is walk in and say, hey, I have pain. And they're like, Let me give you a great example. So I did something really stupid over Labor Day. Did I tell you guys about this already? Okay, I did something really dumb. We were at Kentucky Lake, and there's a quarry. They call it the rock quarry. And I jumped off a cliff along with my older son and his buddies, thinking I'm still 20, right? And I landed smack on my butt, right, off of this like 40 or 50-foot cliff. Blew out the seat of my swim trunks, right? And and seriously thought that I had broke my coccyx, whatever the Napoleon Dynamite guy says, my tailbone, right? And it's been hurt for 2 or 3 weeks. And so finally I was like, all right, I got to go get it checked out to make sure I don't have a broken butt. And they x-rayed it and it was fine. It was just bruised. And the guy that was seeing me, and this was just 2 days ago, was like, well, what are you doing for the pain? And I'm like, well, I got the hemorrhoid pillow and I'm taking ibuprofen. He's like, you need something stronger than that. And I'm like, let's see where this goes. So I'm like, well, what did you have in mind? And he's like, well, tailbone bruises can be really painful. We could do, a week's worth of Vicodin or something. And I'm thinking, so did I take it? How many of you guys think I took the Vicodin? I didn't take the Vicodin, but thanks for the vote of confidence. Okay. But I'm sitting there wondering, in the back of my mind, as all this is going on, I'm thinking, should I take it? Should I not? Maybe I should take it just in case it gets worse or something else hurts. I mean, this is a guy who teaches about this stuff. And in the back of my mind, all of this is going through my head. And he offered, should I take it? And a week's worth? Seriously, a full week's worth of Vicodin, right? Versus like, here's like 4 tablets in case you really get bad butt hurt, right? So that's kind of some of the issue that's come around the subjective experience in people who have pain. Does it hurt? Oh, yeah, right? But what's our expectations as patients and as providers? So the next piece of this really is, and this is a gray area, but I want to make sure that we spend at least a minute or two on this, is the chronicity of pain. All right? Now, is my butt starting to feel better as we move along day by day? Yeah. It's starting to get a little better. It's still sore, but, riding in the car on one butt cheek is starting to get a little uncomfortable. All right? So when was it? When did this injury occur? Was there tissue damage? I would probably say there was. Okay? It's forced me to kind of move gingerly around my rear end area, right? And that's to protect any potentially damaged tissue, but it's getting better, all right? And as it continues to get better, really, we're starting to get maybe about 2-3 weeks out. This is what normal pain looks like. This is what a normal protective pain mechanism looks like. It's forced me to be a little bit safer with my rear end, okay, so that I don't cause further tissue damage, but it's getting better. That is acute pain. Acute pain is good. Acute pain protects you. Now, what about situations where we have worse type of pain, maybe a more serious injury, but we're still seeing improvement as time goes on and the tissues heal? Okay, a good example of this might be a broken bone or an orthopedic surgery, maybe a knee replacement, things that are really invasive, really, really invasive, that take longer than 2 or 3 weeks. We typically consider that subacute pain. So it's not really acute anymore, okay? It's kind of an ongoing process, but there's still healing involved and there's still ongoing improvement. Now, in contrast to that, then we have chronic pain, and this is where the big problem in our country comes from, okay? Is chronic pain that typically it's defined as greater than 90 days, okay? Greater than 90 days is the typical cutoff for chronic pain. The other way of looking at that, and what a lot of people have come into to start believing, is chronic pain is any time that the pain symptom has outlived its usefulness. So let's say 6 months from now, just throwing it out there, 6 months from now, my behind is completely healed. There's no more swelling, there's no more bone bruising or anything like that, but I'm still having butt pain. Has that pain outlived its usefulness? Yeah, it has. And at that point in time, it becomes chronic, okay? Another good example of this would be low back, okay? Let's say that there's no acute inflammation going on after a strain or a sprain, yet you continue to have chronic low back pain or chronic knee pain or fill in the blank, okay? It's no longer protective. That is chronic pain. So when we talk about the chronicity of pain, it's very important when we're assessing it to be able to discuss when the symptoms began and what they're attributable to. Now, the other piece of this is when we classify pain, what we really need to do is start to try to put it down into little buckets of proposed etiologies, because that can help us with our treatment mechanisms as well. All right? Now, when I went through pharmacy school, this is the slide I got on pain. Pain is pain. If you have pain, you're in pain. If you don't, you're not. That's all we knew, right? But what we started to figure out is that in the big scheme of things, and this is probably the easiest way to look at it for you all as students, is when we're about how are we going to treat pain or how are we going to address it. First, we think about chronicity. Is it acute, subacute, or chronic? And then the next piece of this is it nociceptive or neuropathic? And really, I don't want to get down into the weeds on the differences between these two, but in a nutshell, nociceptive pain is normal physiologic processing of a pain signal. So I kick you in the shin, right? And the pain signal moves up through your shin, up through the primary afferents, just like Dr. Schober taught you guys about. They trigger all of these different excitatory potentials. They go up through your spinal cord, up to the brain sends signals back down. That's nociception, that whole process. Neuropathic pain is a little bit different in that neuropathic pain is typically direct damage pathways. So it's not the conduction of the pain signal, like with me kicking you in the shin or landing on my rear end from 50 feet up, okay? But it's things in which we've damaged that pathway, the normal pathway of the pain. Good examples of this include diabetic neuropathy or post-chemotherapy-induced neuropathy. Or if you've ever had shingles, you can get something called herpetic neuralgia. We talked about trigeminal neuralgia, facial pain. These are all situations in which either a virus or a nerve or, a disc, anything along those lines is causing potential or real damage to a nerve. And the reason it's important to differentiate between these two types of pain is that they're described completely differently. So a nociceptive pain, most of you guys can probably think of, you stubbed your toe, it was throbbing and stabbing and it was continuous, and or maybe you sprained your ankle and it was really achy and it felt like somebody was kind of stabbing you in the joint. Those are kind of examples of nociceptive pain. Neuropathic pain is typically described as more electric, right? It's burning, it's electric, it's pins and needles. It feels like that area is asleep, but it hurts. It radiates, so it moves around. Because remember, this is damaged nerve, not damaged tissue. So anywhere along that nerve that's affected could potentially result in a painful response. Okay? So nociceptive versus neuropathic, very important. Now, if we do get down into the weeds on this, we can also break up nociceptive pain into inflammatory pain, which makes sense, right? You hurt something, if there's inflammation, it's driving the pain. There's another type of pain called visceral pain, and you guys know what viscera are, right? They're hollow organs in your body, pretty much. Did I oversimplify that, or is that okay? So like your stomach or your intestines or something along those lines. The reason that we categorize that differently as visceral pain versus somatic pain is that nociceptors, the little nerves that carry pain signals from visceral organs, respond very differently than somatic nociceptive pain fibers do. For instance, I can go in to a patient, I can open a patient up, and I can actually make an incision with a scalpel into their small intestine, and it will not cause them pain. Right? However, if I actually stretch the small intestine, like if you get an obstruction in ileus and you actually have stretching of that viscera, it causes incredible cramping pain, right? And so what triggers a painful response in the viscera can be very different. Typically, visceral pain also can be referred. Let me give you a great example of this that's crazy. People who have liver mets, very frequently they will have inflammation of the hepatic capsule. So basically, the tissue surrounding the liver. But they don't claim that this area hurts when this occurs. It gets referred to their left shoulder. Isn't that crazy? And that's commonly considered a visceral pain syndrome. Now, we're going to talk on Monday a little bit about the differences between sympathetic and centrally mediated neuropathic pain. But a great example of this is when the pain is not originating from a peripheral nerve. So for instance, diabetic peripheral neuropathy. I know I keep coming back to that, but I feel like that's one that most of you guys are very familiar with. That's damage to the distal small nerve fibers, right? Now that would be considered a peripheral neuropathy. However, we can have central neuropathies too, where the damage is not to the nerve that's in the extremities or in the body, but it's in the neurons in the brain. So a good example of this might be the pain associated with multiple sclerosis, or believe it or not, fibromyalgia. Okay? These are centrally mediated pain syndromes. How are we doing? Am I moving at too quick of a pace, or is this all right? Okay. How many in here are not in the pain elective? Can I see hands? Okay, a decent amount. So for those of you who are, some of this will look like review, but the other piece of it too is for every year for the last 12 years, I've been doing basically a lot of overlap. And so some of the stuff for the people who are in the pain elective, I saved for the therapeutics course because I knew I'd have this time, so there wasn't a bunch of overlap. So I just wanted, if you're thinking, man, I haven't heard this yet, I got ripped off, that's part of the issue, okay? So how do we assess pain? So we've talked about how to categorize it, the chronicity, the characteristics. Now, how do we actually assess it? And this is actually becoming more and more important because the Joint Commission, the people who make sure hospitals are doing what they're supposed to, just released new standards on assessment of pain. And so this is really a big area, and most hospital pharmacists are getting intimately involved in this part of therapeutics. So the first thing you want to do is, you know, what happened? Well, I slammed my finger in the door. Okay, well, that's probably what's causing your pain, right? So the first thing we want to do is what happened? Precipitating, all right? What's the quality of the pain? And when we say quality, you know, we're not talking about like, it's really good. I'm talking about how would you describe it? What are the characteristics? Is it achy? Is it cramping? Is it shooting? When I have a patient come in that we see on the pain service, I have them fill out something called a brief pain inventory. And on the back of it is like 40 different words that they can use to describe their pain. Almost everything you'd ever heard of. Okay? And I ask them to circle everything that is applicable to what they're experiencing. And when you look at that thing and you look at all the different words that they've circled, you can almost, just by glancing at it, go, this is more neuropathic quality versus nociceptive, okay, or inflammatory. So make sure we know what the quality is. Where is it at? Okay, is it radiating? How severe is it? And this is, again, it's what the patient says it is. Now, what's going to wind up happening, gang, is right now, so this is one of those, I got to tell you what the company line is now, but I'm also going to tell you where things are headed, okay? Right now, everybody wants to know, tell me about your pain on a scale of 0 out of 10. I even taught you guys that last year, I think, right? What is 0 is no pain at all. 10 is the worst pain imaginable, right? And give me a score. What is it? Is it a 7? Is it an 8? I need to know, because that's going to dictate all of this other stuff. And in reality, that's probably not the best way to go about this, okay? Probably the best way to go about actually assessing severity is, what's it keeping you from doing? Can you walk? Can you get up and go to class? Can you work out? Can you enjoy your family? Blah, blah, blah. Okay? And there's a big, big push right now, especially in hospitals, because right now, if you're in the hospital and you say, I have an 8 out of 10 pain, they're like, there's a standing order, and that means, okay, you get 2 Vicodin or a shot of morphine. But if you say 4 out of 10, you only get 1 Vicodin or a Tylenol. I mean, I'm just pulling this stuff out of my behind, but you guys get the drift. And what we found is, well, a lot of patients will say, no matter what, I'm a 10 out of 10. I need whatever you got, right? And then what we wind up doing is we over-treat them, and people get hurt. So instead of saying, give me a number, it's like, hey, you know, I noticed that you were able to get up and walk to the bathroom on your own. So activities of daily living and things like that that will help drive the actual pain assessment. Okay? So PQRST and then U is for medications utilized. I don't care which method you guys use this, use old carts, which I think you guys are very familiar with. I don't care, but be consistent and use one of them. Okay? Either way, no matter which one you use, you're going to come up with the same types of information, and you're going to need those for symptom analysis. The next piece of this is, what tools are you going to use? Okay, so we have a number of different types of tools to assess pain, and the reason that we spend so much time on talking about these assessment tools is that we don't have a test we can run. I can't pull a hemoglobin A1P and figure out exactly what your last 90-day pain average has been. I don't have that, right? I can't do it. I can't get an X-ray of your back and predict how much pain you have. There's no correlation. Or an MRI of your knee. There's no correlation, okay? And so I have to be able to assess it solely based off your subjective responses. And when we do this, we basically are looking at unidimensional or multidimensional assessments. And it's really straightforward. Unidimensional, all I want to know about is your pain severity. On a scale of 0 out of 10, what's your pain? Okay, on multidimensional, it's going to be on a scale of 0 out of 10, tell me about your pain, and then tell me about your how this is affecting your sleep and your activity. Tell me how your pain was at night versus during the day. It wants to know all of this different stuff, all of these different things. Now, when we talk about unidimensional, we also have to discuss whether or not certain things are validated for that particular patient population. You probably cannot go up to a 2-year-old and say, on a scale of 0 out of 10, how's your pain? And they're like, blah, 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 right? You don't know. So we might use a FACES scale for pediatrics, or we may use something called a nonverbal checklist for patients who are older and can't communicate with us, okay? The multidimensional pain scales, it's really whatever works best for you and whether or not you're filling it out or the patient's filling it out. So for me, I use the brief pain inventory. It's the shortest of the big assessments. I have the patient fill it out while they're in the waiting room. It works out great. Okay? So let's practice real quick. I want to make sure that we're taking a breath because I know I'm going quicker than I normally do and we're covering lots of stuff. But let's consider a 49-year-old female with type 2 diabetes, and she complains of burning, tingling, pins and needles in her hands and feet for the past 8 months. It's starting to affect her ability to take care of her grandkiddos. So A, what type of pain is this from a chronicity standpoint? Is it acute, subacute, or chronic? Chronic, thank you. So you guys got it, okay? What type of pain is this probably characteristically? Neuropathic, good. You guys got 100% so far. And what type of pain scale do you think would be most beneficial to figure out not only her severity of pain, but the interference with her daily life? Multidimensional. You guys are so smart. I love it. This is the best class I've ever had. Okay, so let's talk about some important definitions around pain management. These get thrown around all the time, and it drives me up a wall. It's like nails on a chalkboard for me. And the problem is with all of these government agencies getting their little sticky fingers in all of what we as healthcare professionals more and more and more, these terms get thrown around without any care about what they're actually talking about. Number one, dependence, and I hear this all the time. That patient has opioid dependence. Every patient on opioids has dependence. That is the most asinine thing I've ever heard in my life. Everyone on beta blockers has dependence. Everyone on clonidine has dependence. You could argue that people on insulin are insulin dependent. Okay? Dependence does not equal addiction. Dependence is when if you are on something and I take it away quickly and you have a withdrawal syndrome from it. That's all it is. Dependence. Your body is dependent on that to keep from getting whatever symptom you want. Is that addiction? Is that substance use disorder? It is not. If you are on opioids for longer than 3, maybe 4 weeks, you will become dependent on them. That means you will get sick if you abruptly stop them. Now, that is in contrast to addiction, and it's really not called addiction anymore, gang. Okay? Am I going too quick? Need me to back up? Okay. You guys stop me, please. Don't. So dependence, you get sick if you come off of it, but that doesn't mean that there's a co-occurring psychiatric or psychological issue going on. Okay? Now, they don't call it addiction anymore. They call it substance use disorder, or particularly opioid use disorder. Is addiction this semester or next semester? Okay. Now, if Dr. Lepsch is up here and she's like, you know, this and that, don't be raising your hand being like, Herndon told us not to use that word anymore. Still do use it, okay? But it's not in the diagnostic manual of psychiatry any longer, so there's not a diagnosis code associated with addiction. Right? So like when I go in and I try to chart on a patient, I can't type in addiction. It's substance use disorder, okay? Now, what is that? Well, could a patient have substance use disorder and be dependent on opioids or alcohol or benzodiazepines or fill in the blank? Absolutely. Okay. But what differentiates the two is that there's a loss of control over use, right? So these patients know that it's harming them. They're not taking 2 or 3 Vicodin a day so that they can get up and walk to school and be a good part of society and pay taxes and do all this stuff, right? It's harming them personally. It's harming them professionally. They have cravings. They can't control their utilization of the drug. They might steal and commit crimes to get them because they have this escalating use, right? Complete loss of control. That is addiction or substance use disorder. Now, the big question around this is, does everybody that's exposed to opioids for pain, right? Like if I'd taken my week of Vicodin for my butt pain, would I have become addicted to it? And what predicts who does and who does not? That's the big thing that we're wrestling with right now in the healthcare community, right? Who should we expose to these medicines? Okay, now, the next piece of this is we have to figure out when we're monitoring. So let's say this guy gave me my week's worth of Vicodin for my butt pain. If he was doing his job right, he'd be wanting to know about any problem behaviors that I might have associated with those drugs, okay? Now, the overarching term that covers everything are called aberrant drug-taking behaviors. You're not assigning any blame or description. You don't know for sure. All you're doing is saying, hey, look, something ain't right. Here's an example of that. You guys all know what the Illinois Prescription Drug Monitoring Program is, right? So let's say I get on the ILPMP and I see that one of my patients that we're giving opioids to got opioids from a different provider. Is that addiction? Is that dependence? Is that abuse? Is that misuse? We don't know. We don't know. Maybe the patient broke their femur and was in the hospital and got discharged with 2 pills of something. Who knows? But we don't have enough information. Now, is that an aberrant drug-taking behavior? Kinda. All right? Now, if we want to get further down into the weeds, misuse is when you use a medication other than how it's prescribed. And I think, did I type these? I know I put these at the deck right before class. Okay, the deck. Don't get too crazy about typing on this. But misuse is when you're using it, but you're still using it for pain. I told you to take 2 of these a day and you're taking 3 for your broken back, right? And you're using them for your broken back. That's misuse. Abuse is when I said, I'm going to give you, I told you to take 2 of these a day for your broken back, and you're using 20 of them on Friday night with a handle of gin to get rocked, right? That's abuse. Does that make sense? Okay. How are we doing up here front row? You doing?
Really good.
He said really good. All right. You got any? No?
No pain.
No pain up here. Good, good. I like it. You doing okay, ma'am? You're re-downloading the slides? I like it. All right. So the next big term that's always confused with addiction and all of this other stuff is tolerance. Tolerance is something else that everybody exposed to opioids eventually will experience. Tolerance is when you need more of something to get the same effect. How many of you all in here would consider yourselves a cheap date? One beer and you're... Couple of you. Now, how about those of you who are like, oh, I'm not a cheap date? Okay. Were you always not a cheap date? No. Everybody started out as a cheap date. Okay? And that is from tolerance. When I'm talking about alcohol and not feeling completely straight and narrow. Okay? So, eventually you get tolerant to the use of that substance. There's no difference with opioids, and that does occur. Now, I'll tell you clinically, I have no data to back this up, but clinically, having done this for 15 years, what I see is that patients get tolerant to the euphoric effects, anxiolytic effects of these drugs much quicker than they do the analgesic effects. So what does that mean? That means that patients who are using and I'm just going to use Vicodin because it's easy to say, okay? Patients who are using Vicodin to get high or to feel more calm because they're stressed out, the effectiveness of that drug for those types of symptoms goes away very, very quick with continued use, maybe 2 or 3 weeks. Usually the analgesic effects of the drug can last 6, 12 months before you start getting tolerant to it. So what do you think happens to the patients who aren't using these drugs for the right therapeutic intent? They quit working really fast, okay? Now, the next piece of this is pseudo-addiction, and this is a term that they've been trying to get rid of for probably about 5 years now. And I think it's important that you at least know what it means, okay, even though they're trying to phase it out. Pseudo-addiction is basically when you display addictive behaviors because we're doing a crappy job managing your pain. If you have a knee replacement surgery and I give you 1 Tylenol 3 a week to take as your post-op pain management, and you go to another doctor and get pain pills from another person, is that an aberrant drug-taking behavior, yes or no? It is. Is it abuse or misuse? Kinda. She's not doing what I told her to. I told you to take 1 Tylenol 3 a week for your knee replacement. She's not doing what I told her to do. Is she an addict? See what I'm saying? There's a gray area here. And that's what people who are really hardcore pain management advocates, patient advocates, they will use this term. They don't have addictive disorder. They have pseudo-addiction. Okay? Last 2 are super easy. Hyperalgesia. Hyper means more, right? Algesia is pain. Analgesia is no pain. Hyperalgesia is too much pain. So it's basically when something that should hurt hurts worse than it should. You guys ever get a sunburn really bad before? What happens when the sun touches it later on, like a day or 2 later? Holy crap, right? That is hyperalgesia, okay? Something that should hurt that hurts worse than it should. Allodynia, the second term, is when something that should not hurt does hurt. Let's go back to diabetic peripheral neuropathy. Me lightly brushing your skin with a Q-tip or a sock or a dress or a pant leg should not hurt. But patients who have diabetic peripheral neuropathy, it sends them through the roof. It's exquisitely painful for them. That is allodynia, when something that should not hurt does. Remember cutaneous allodynia from the Headaches Monday? There you go. Okay? How are we doing? Are we tracking? Are you guys too slow, too fast? Going off on too many tangents? Yes, ma'am. Okay, so she brought up a question that we could talk about for probably about 2 weeks. Okay, how do you balance pseudo-addiction and the opioid crisis and the overuse? Okay, I don't have a good answer for you to make it short and sweet. I think the big piece of this is my personal opinion is that overprescribing of opioids, and we'll talk about this in just a minute, I think the overprescribing of opioids has actually contributed to some of the pain crisis, not the opioid crisis, but the actual chronification of pain. The other piece of this is that we prescribe them for too long, right? I don't need a full week's worth of Vicodin for my water injury, right? And in fact, what they're trying to push for is that post-operatively for acute pain, that we limit the prescriptions of opioids for about 3 days after surgery, because what you see is that the actual severity of the pain starts to go way down after most types of surgeries after the duration. Okay, subacute. Now, if you were on opioids around the clock for 7 days or more, that increased your risk of continued use of opioids daily eightfold. Eightfold. And you know, that's good that you can stop whenever you want. I'm proud of you. I don't have a problem. You have a problem. All right. So, anything else about what we've talked about? Any other issues? Okay, let's jump into the actual opioids. Okay, so we basically have 4. I mean, we could argue that there's actually 8, but we have 4 major types of opioids. Okay, and I guess to think about this, you know, we have a number of different opioid receptors that do different things. Okay, have we ever done that like receptor game with you guys? Did we do that? You 3 want to play the receptor game? Be my receptors. You ready? Okay, be a receptor. Okay, this is what it basically looks like on the neuronal cell membrane. So you're going to be my mu, you're going to be my kappa, and you're going to be my delta. Okay? And they all hang out right here together. They're G protein coupled receptors. So there's going to be second messenger downstream effects. Most of our drugs that we use bind mu. Okay? Most of them we use bind mu. All right? Now, that's going to be your morphines, your hydrocodones, your fentanyls, your meperidines, hydrocodone, oxycodone, oxymorphone, methadone. It's like a rap, right? Now, the other piece of this is that we have drugs called partial agonists, okay? And we've talked about this with Dr. Schober before, and they don't come in and they don't like fully get in there, okay? They just kind of, they lightly like just partially bind it, okay? And so you get this, you know, there's a little bit of a receptor tickle, so to speak, but you don't get full response, okay? Now, the other types of drugs that we have, and they're not very frequently used, I'm not going to you, don't worry. But the other types of drugs that we have are called kappa agonist, okay? And the weird thing about the kappa drugs is so they come in and they bind kappa, which is also an analgesic receptor, okay? But they usually block mu. They bind kappa, they block mu, okay? So really they're coming in and they're mostly here and they're like, you know, doing the, what is that called? The Heisman? Is that what that's called? Okay. Now, most kappa drugs, while they're here binding and they're blocking here, they're kind of tickling over here a little bit. Delta, okay? You can put your hands down. You've been a wonderful participation here. But yeah, give them a big round of applause. Okay, now, all three of these receptors can contribute to analgesia. So if I bind kappa, I get pain relief. If I bind delta, I get pain relief. If I bind mu, I get pain relief. Where things come into play is that each of them have different kind of quirks. Did you say you have some quirks? Okay. So your quirk is euphoria, right? Euphoria and respiratory depression. So euphoria and respiratory depression. Your quirk is unfortunately psychosis, okay, and dysphoria. Euphoria is, oh, that's good stuff, right? Dysphoria is, oh, I feel awful. Does that make sense? So makes you feel good, makes you feel awful. This guy, you're right, you get some pain from him, but he just makes you crazy. And actually the kappa or the delta opioid receptor, remember mu, kappa, delta, the delta opioid receptor almost looks exactly like the PCP receptor. You guys know what PCP is? Yeah, remember that? Okay. So, makes you crazy, makes you feel crappy and crazy, gives you respiratory depression, but makes you feel so good, right? Euphoria. Does that make sense? Will this help you guys remember what these receptors do? All right, let's move on. So, we have mu agonists, and that's predominantly what you'll see used, the mu agonist. We're starting to use more partial mus, like buprenorphine. We see that in Suboxone, but we also see that in a butrans patch. The mixed agonist antagonist, these are 3 drugs that you'll see usually more frequently on the hospital side, but we talked about it on Monday that we do still see some butorphanol nasal spray being used. But remember, when these drugs are called mixed agonist antagonist, remember what they agonize and what they antagonize, okay? Remember, stimulate, block over here. So why is that important? So if you think about just the receptors that these drugs bind to, if I'm on, let's use Vicodin as an example, if I'm on 10 Vicodin a day and I go into the hospital and they give me a shot of now bufene or butorphanol, what do you think that's going to do to me? It's going to put me into acute opioid withdrawal, like immediately. Okay? It's like reversing somebody with Narcan. And it can also, if I'm on it for a legitimate reason, like, okay, I may have like, maybe I'm on it for my sore behind, but what if I have cancer and I'm in an acute cancer pain crisis and you reverse me with one of those drugs? Have you guys heard this before? This is one of the only things I remember from my pharmacology class in school. So please remember this. Buprenorphine can do the same thing. That's why we tell you to come off your drug before we start Suboxone for a day or two, because we don't want to put you in an acute opioid crisis. Okay? Are we good? Any drugs up here that you guys don't recognize? Pentazocine is an old one that hadn't been used in years, but it's starting to come back. And then these other drugs, these antagonists down here, hopefully you've heard of naloxone. There's a drug called naltrexone that we can use both for opioid addiction and for alcohol addiction. And then the rest of these drugs are peripherally acting opioid antagonists, so we just use them for people who can't. Have I shown you guys that? Frank can't poop? I love that video. No, we don't have time, but Frank can't poop. Okay, so these are the opioids based on the receptor they bind to. The receptor they bind to. These are the opioids based on the Kreider classification. All right, these are the chemical structures of these drugs. And you have phenanthrines, which makes up the bulk of them. You have benzomorphans, phenylpepridines, diphenylheptanes, and then there's really no good way to classify these other than to call them centrally acting opioids. Why do I have this slide on the board? Because very rarely what will happen is that you'll see somebody with a true opioid hypersensitivity. I'm not talking about they get itchy or they get constipated. I'm talking about anaphylaxis. It's very rare, but it will happen sometimes. And what we basically ask you to do is if you are going to have to use a drug in somebody that, say, had an anaphylactic reaction to morphine, what we'd really prefer is that we try to avoid the drugs in this column and start thinking about drugs in some of the other columns. Okay? Make sense? That's all I want you to know from this. Got it? Any questions? Okay. So let's run through these drugs super quickly. Now, morphine's our gold standard. We compare everything to morphine in terms of its efficacy, its side effects, how long it works, you name it. General rule of thumb with morphine is that it's going to last about 4 hours. The duration of analgesia for these drugs is going to be about 4 hours. 4 hours. The onset of action comes primarily from how you give it. Now, important piece of this is that morphine is actually metabolized through glucuronidation to two metabolites, okay? And it's kind of like the good brother and the evil brother. One of them is very effective for analgesia, okay? And that would be the morphine 6 glucuronide. And they're actually trying to work on isolating that particular glucuronide metabolite. It's about 40 times the potency of its parent drug. The problem is that it also comes with morphine 3 glucuronide, which is neurotoxic. It can cause confusion, it can cause seizures, it can even cause hyperalgesia. Okay? And so for those of you who are planning on going to work in a hospital, one of the first things a clinical pharmacist typically will do is they'll take a gander at somebody who's been ordered morphine and they'll look to see what their renal function is. Because in patients whose renal function is, say, 30 mils per minute or below creatinine clearance, we try to avoid morphine because you can accumulate that nasty M3G metabolite. Otherwise, morphine's cheap. We know how it works. Unfortunately, it has a very bad rap with the community. So like morphine, there's really no big difference in all of these drugs in terms of how they work. But a lot of it is perception. Oh, I don't want morphine. That's what they gave Saving Private Ryan right before he died, right? Everybody has this idea of, well, we only use morphine in hospice or, you know, whatever, fill in the blank. Okay? But in actuality, it's no worse or no better than hydrocodone or hydromorphone. They're all basically the same. Codeine. Does anyone send out Tylenol number 3 in here? Worthless. Worthless drug. So codeine is a prodrug. It has to be metabolized to morphine. So codeine is metabolized to morphine. So why not just give them friggin' morphine? What's the point? Perception. Okay, yeah. What class is morphine? Schedule deuce. Tylenol 3, trace. Call it in, baby, right? So, codeine is metabolized to morphine by CYP2D6. Oh, dang, he's bringing Worthington up in here. 2D6. How many of you in this class lack that enzyme? 15%, yo. 15% of you guys can't even metabolize codeine to morphine. Codeine has no analgesic activity on its own. So 15% of the patients you give Tylenol 3 to, worthless, other than causing constipation. Now, you don't have to worry about using it for cough because codeine by itself doesn't have to be metabolized to be an antitussive, just for a pain management drug. Let's talk about hydrocodone. Hydrocodone, if we talk about the actual metabolism of this drug, it does have an active metabolite, but it is also active as a parent. So hydrocodone by itself is good for pain, but you also get some pain relief from the hydromorphone metabolite. It was, up until 2 years ago, the most highly prescribed drug in the US. Not the most highly prescribed opioid, but the most highly prescribed drug. That's starting to come down. You can now get hydrocodone without the acetaminophen component. We have 2 up here. One is Zohydro, which is a controlled release hydrocodone only product. The other is a drug called Hysingla. I don't know where they come up with these names, but whatever. And so, and those are, you talk about being watched closely by Big Brother. Those 2 are really watched closely, okay? Hydromorphone is the active metabolite of hydrocodone. Hydromorphone may be a little bit less familiar to some of you because, you know, it's really not a drug that's used super commonly outpatient. It's very commonly used inpatient. It has a number of brand names. Probably the most common one is Dilaudid. Some of you may have heard Dilaudid before. It also has a long-acting called Exalgo, EX, and then ALG, right? So it's extended release, ALG, analgesic. Catching it? You think they thought long and hard for that name? Probably. so Exalgo is the long-acting, has similar duration of action. It is much more potent than morphine. And we're going to talk about potencies here in just a minute, but it is much more potent than morphine. Oxycodone. I'm sure a few of you have seen this in your pharmacies, right? Either by itself or combined with acetaminophen. Nobody? Everybody. Everybody has seen this drug, right? It also is an active parent drug. So oxycodone by itself, you get analgesia, but it's also metabolized to an active metabolite called oxymorphone that they just took off the market. Did you guys see that in the news? They took Opana ER off the market. Yeah. Opana ER was oxymorphone. It's, again, goes through CYP2D6. Basically every opioid but morphine goes through CYP2D6. Okay? It has a little bit shorter duration of action. It also has got a little bit more lipophilicity than some of these other drugs. So if I'm getting drug into the CNS faster, what do you think that does to abuse potential? It increases it, right? Hence the nickname hillbilly heroin, oxycodone. Have I told you guys about the documentary OxyContin Express? Did I tell you guys about that? That's your homework tonight. I'm serious. Hulu or YouTube. It's a 45-minute documentary that was done by Vanguard. It's called OxyContin Express. And it basically is all about how the drug and opioid epidemic got started, and it all started in Broward County, Florida, which is just north of Miami-Dade, right? All right, oxymorphone. We just kind of talked about it. Active metabolite of oxycodone, 2 times more potent than oxycodone. The immediate release available, the IV is still available. The extended release, they are moving from the market, primarily because they can't get it to have appropriate abuse deterrent properties. It has a longer half-life, and also you have to be very careful about taking it on an empty stomach, because if you take it with food, it shoots up the amount that's actually available. And believe you me, there are patients that know about this, okay? There's a website called bluelight.com where they talk all about pharmacokinetics. You could probably learn more about opioid pharmacokinetics on bluelight.com, which is like a bulletin board for abusers, than you could in pharmacy school, I guarantee you. They actually have a step-by-step approach on there on how to separate naloxone from buprenorphine in a Suboxone film. That's some Breaking Bad action right there, right? Okay, why don't we take a quick break? I need a quick break. And we'll come back at, what slide are we on, by the way? 20? Okay, we're actually, 20. Yeah, we're actually tracking. We're on time. Okay, take a quick break. Why don't we come back in 5 and we'll get rolling again. Herndon was Lincoln's law partner. Did you know that? I'm not related to him. Okay. You guys look like you're having fun. Who are you laughing at? Okay, let's get going, gang. So right now we're back into the opioid. We're still talking about opioids, bless you. And probably the one that is causing the most havoc in the US right now as far as overdoses are fentanyl and its derivatives. Fentanyl and its derivatives. So we have crazy people down south of us that are actually making acetyl fentanyl. Okay, acetyl fentanyl, which is about 3/4 as potent as prescription normal fentanyl, and they're cutting heroin with this. Okay, and now we also have from Asia, we have another synthetic fentanyl coming over called carfentanil, which is supposedly somewhere between 100 and 1,000 times the potency of fentanyl that we have in the US. Holy moly. I mean, think about that. I mean, we're starting to talk about like national debt level numbers of potency. It's crazy. Okay. Fentanyl and its derivatives are the most lipophilic of the different opioids. And hence, that's why we can use it transdermally. Okay. Very lipophilic. There's good and bad with fentanyl. The good is it starts working really, really fast. So that may be a really good situation if you're trying to deal with acute pain in a hospital and you have IV access, or you have malignancy or breakthrough cancer pain, and you want something that's going to work really, really quick for breakthrough pain. The bad part is the duration of analgesia is pretty short. So, you know, somebody who's using like IV push fentanyl in the hospital, it's not going to last very long, whereas the others may last 4 hours, 3 hours. This one may last an hour. So it can be problematic. So it gets into the CNS really, really fast, and then it dips out really, really fast. So what do you think the abuse potential of fentanyl is? Very high, okay? Very, very high. Now, fentanyl, unlike the others, is metabolized via 3A4 to inactive metabolites. So fentanyl is the active parent drug. Guys, you've got to watch drug interactions with this drug. I'm telling you, this is like a very narrow therapeutic index drug. So if I go from an AUC of X to Y because of a antibiotic drug interaction, it's not a theoretical, it's potentially fatal. Okay, so don't just click the bypass button on drug interactions when it comes to fentanyl. Fentanyl, probably the most frequently used method of delivery for fentanyl is the patch. Are you guys still seeing fentanyl patches go out quite a bit? It comes in a 12, a 25, a 50, 75, and 100. I've had a patient that was referred to me from, most of the patients I get from St. Louis is because their doctors have lost their license. Right. So you talk about cleaning up big messes. The most I've ever seen a patient where at one time was 7 100 microgram patches at a time. Okay. I mean, it's pretty close to just making them a vest out of them, you know, stitch them together and wear them. Okay. Most of the folks that I see that come over on really high dose fentanyl are usually in the 2 to 3 patch range, 2 to 300 mic patch range. Okay. Now, it's really easy to go from morphine to fentanyl, right? There, you open up the prescribing information and it tells you this much morphine, you use this much patch. Unfortunately, though, going back is harder. And an easy trick for you guys, if you're thinking about, well, does this make sense clinically? Is this safe? Is the old 2-to-1 trick. So for every 1 microgram per hour the patch is, assume 2 milligrams per day of morphine equivalent. So let's give you an example. You guys ever see 50 mic patches go out? Sure. 50 micrograms per hour is roughly equivalent to 100 milligrams per day of morphine. All right? So the reason I'm telling you guys all this is if you have somebody who's taken 2 hydrocodone a day for their knee pain or whatever, and then all of a sudden you get a prescription for a 75 microgram fentanyl patch, how much morphine is that? That's 150. Would you guys feel confident filling that prescription? Please, everyone, nod your head no. No, you do not. Okay? You talk about making an impact on patient safety. Here's a big one. When you guys get those prescriptions for fentanyl patches, eyeball it. If you didn't fill the last one, if you didn't fill the last fentanyl prescription and somebody brings one of those in, it should be like, you should be like a sleuth going after information. What were you on before? How many milligrams? How many times a day? How is it prescribed? Because you're the only one then at that point in time standing between them and an overdose. Okay? And I'm telling you, I see it all. You know, and unfortunately, you only read about 1/10 of the people who die, honestly, every day from these drugs. Okay? So make sure you know roughly what you're given. The other big piece, let me go back to transdermal, sorry. When you take a patch and you put it on, okay, even though it is lipophilic, it takes it some time to reach equilibrium with the fatty tissue, the sub-Q fascia underneath the skin. And so the general rule of thumb with a patch is it takes about 12, somewhere between 12 and 18 hours for you to reach kind of equilibrium. Now that's not steady state. We're not talking about like choline level stuff. We're talking about just when do you start to get adequate analgesia from that patch based on drug levels. So 12, somewhere between 12 and 18 on. And same deal, when you pull it off, it's going to take between 12 and 18 hours to get that out of the skin. Now, I'm not talking about half-lives here. I'm talking about that drug, that lipophilic drug, leaching itself out of the fat tissue. So a good example is, don't assume if I put a fentanyl patch on you that you're going to start feeling better right away. It's going to take 12 to 18 hours before you start to feel the effects of that patch. The flip side is if you come in to the hospital and you have one of those patches on, don't think just because I pull that patch off that you're like, boom, fentanyl's gone. Okay, you got to take into consideration that that patch was just on and that you're going to have, 12 hours or so of decreasing but present levels of fentanyl in the body. All right, let's talk about transmucosal fentanyl. Who knew that there were so many different transmucosal fentanyl products? Have you guys all heard of all of these different drugs? It's crazy, isn't it? There's polypops, there's nasal spray, there's sublingual spray, there's buccal tablets, buccal films. And to be honest with you, the idea behind these drugs is very good, okay? The idea behind these drugs is cancer breakthrough pain comes on very, very fast. It's very, very severe, and then it goes away quickly. So if you have cancer breakthrough pain and you're like, well, take a Percocet tablet for it, and it takes 30 to 45 minutes for that to kick in, breakthrough pain's done and gone by then, right? However, these products, you get levels and analgesia within minutes from these drugs. So actually, idealistically, they're very good. The problem is they're also very abusable. Okay? And because of that, they've come up with a REMS program for these drugs. REMS stands for Risk Evaluation Mitigation Strategies. And so the TERF, and that stands for Transmucosal Immediate Release Fentanyl, TERF. All right, all of these programs are under the TERF REMS program. And basically what that means is the doctor has to take training, or the prescriber has to take training, the pharmacist has to take training, the patient has to be registered, and you have to send in a signed prescriber-patient opioid agreement. So there's a lot of steps behind this. Is anyone in here actually dispensing these? Is anyone in here work at a pharmacy that does? Okay. You all as pharmacy students can actually go in and take the TERF training, but you have to be a pharmacist, a licensed pharmacist, in order for that to allow your pharmacy to order in these drugs and to dispense them. Okay? Here's the take home on these. We're going to teach you guys, I think in just a little bit, how to do conversions between these drugs. The fast-acting fentanyls, the lollipops, the buccal tablets, the ones that are used for breakthrough pain, do not ever convert milligram for milligram or microgram for microgram. You always start at the lowest dose with these drugs, with these particular drugs. I know there's all kinds of fun math we can do with opioids and all these little equations and stuff. Don't mess around with these. With these, you start as low as you can go and titrate up as necessary. Okay? Just the transmucosal, the fast-acting fentanyls. Always start at the lowest. The other one, like the patch, I'm like, well, you can do 2-to-1 and figure out your conversions. With these, you can't use the 2-to-1 conversion. Okay? You always go low. Always go low. How many of you guys have ever seen a Dum Dum lollipop? Okay, everyone knows what a Dum Dum lollipop looks like? Okay, how many of y'all have ever had a, what do they call they used to call them Lickamades. I think they're called like dip sticks or what? Fun Dip. How many of you have Fun Dip before? You know the little stick that you have? That's my favorite part of Fun Dip. Do you guys like the Fun Dip stick? Okay, so let me share something with you. Generic fentanyl lollipops, the Actique or the OTFC lollipops, they look almost exactly like a Dum Dum, and they taste exactly like a Fun Dip. So you tell me how that might be risky. Okay? So the most important take home here on this for you guys, if you do get licensed or you are working, and you will get licensed, but if you get licensed to dispense these turfs, is that you talk about disposal. Because there are reports, you guys Google kids who have died from getting into this stuff, there's thousands of reports in the media about this. Okay, we're going to talk about meperidine or Demerol. It's not being used that frequently anymore. It was really big drug when I was going through school. That it's being phased out because of toxic metabolites. You know, it wasn't a terrible drug, but you all probably will see board questions regarding Demerol. Are you stretching or you have a question? Yeah. You do not use benzodiazepines to wean somebody off of an opioid of any type. There is nowhere in the addiction medicine literature that, in fact, they recommend absolutely avoiding benzodiazepines for withdrawal symptoms from opioids. Yeah, don't go to that doctor. Was the patient coming down or just cold turkeyed? Okay. I'm going to wean you off meth with this crack. Right. Okay, methadone. I've got a love-hate relationship with methadone. Methadone can be used in two different ways. One as what's called a medication-associated therapy or treatment option for people who have a substance use disorder. So methadone is a replacement for heroin, morphine, whatever it is that they had problems with. And this is because of its really long half-life. It can be taken once a day. It can be observed, right? It could be observed dosing. And we can also use this in multiple daily doses for an analgesic. It is a very complex drug, very, very complex, all right? And we're starting to see it used less and less as an analgesic, although I still think it's one of the most effective opioids that we have when it's used correctly, okay? One of the big issues with this drug is that it can cause QT prolongation. And so monitoring EKGs is warranted. Believe it or not, in my collaborative practice agreement at the clinic I'm at, I'm specifically allowed to order and interpret EKGs for patients who are on QT prolonging opioids. And so this is one of those where they come in, you check the box, you get it done. We look to make sure, the QT is under 500. And then we do business as usual. The issue with this drug is that it works in so many different ways, and the half-life is unpredictable. And a lot of people got hurt on this drug for a number of different reasons. Probably the most common reason is that they tried titrating it too quickly. So you think about a pain drug, you're like, hey, I'm going to take this Vicodin for my, shattered leg, and I expect to feel better in an hour or two, right? With methadone, unfortunately, because of the half-life, it may take a week before you see the full effects of whatever dose you're going to put a patient on. So if you're dosing it 4 times a day for pain, you're not going to see what you're actually going to get for about 7 days, because it doesn't reach steady state until that long. And so what people were doing is they're like, calling back, hey, it's been 2 days, I'm not feeling any better. All right, let's increase the dose. And 2 days later, okay, I'm still not feeling as good as I probably could. Let's increase the dose. And then they wind up overdosing, because you don't see the max until about day 7. All right? So number 1 with methadone, number 1, you do not ever titrate the dose more frequently than 7 days. If you see somebody doing that in your practice, this isn't like the serotonin syndrome warning screen that you might see at your pharmacy. This is one of those where if you have a patient, it's like, take this many now, and then this many, and then this many, and it's like all within a 3 or 4 day period. That's one of those where it's very reasonable to pick up the phone and be like, hey, look, I'm not questioning your, all-knowing expertise, but, what's going on? We just want to make sure that this patient's safe. And I specifically ask patients to get referred to me that are on methadone for methadone maintenance clinics. Are they monitoring your EKGs? Right? And that's not a bad idea. And what happens if you guys said, hey, are they monitoring your EKGs? And they're like, no, should they be? They might want to. What do you think that patient's going to do next time they see the doc? Hey, do I need an EKG? Yeah, I guess you probably do. Right? Surveyed prescribers of methadone about 3 years ago in the state of Illinois. You know what percent of methadone prescribers monitor EKGs according to the actual guidelines on EKG monitoring? 2%? 20%? 1%? 5%? 5%. Let me ask this real quick, not to jump back. So we're monitoring EKGs because of QT prolongation. Are there any drugs that you guys can think of right off the top of your head that cause a lot of QT prolongation? Citalopram, what else? Levaquin, fluoroquinolones, what else? Tricyclics, right? What drug did you guys just learn about in here for psychosis? What's Geodon? Ziprasidone, does that cause QT prolongation? I hope you guys learned that. What about ondansetron, Zofran? Nobody uses that, right? QT prolongation. Hydroxyzine, QT prolongation. So the drug interactions are there. The other piece of this is that potassium and calcium abnormalities can also contribute to QT prolongation abnormalities. So remember that those things need to be monitored too. How do you dose it? Well, the potency of methadone changes based on the total morphine equivalents that you're getting per day. And we're going to practice this for a few minutes here in just a minute. But think about if you are on, do you guys still see MS Contin or morphine CR30 go out? That's a reasonable drug. Let's say you're getting that 3 times a day. Half of the patients are going to need 3 times a day dosing of long-acting morphine. It's about half need twice a day, half need 3 times a day. So if I'm getting 3 30s a day, how much am I on total daily? 90? Okay, so if I look at this little chart here, what's my conversion? 3 to 1. So how much methadone daily would I need? How many? 30 milligrams total a day of methadone would be equivalent. The problem with methadone too is that because it's an MDA antagonist or a glutamate antagonist, you are expected to reduce the dose for cross tolerance by about half. So now how much am I getting? 15 a day. So basically 2.5 to 5 milligrams 3 times a day from 30 milligrams of morphine. You guys see how that works? Okay. Here's my recommendation to our docs. If you're going to use methadone for pain, I don't care what they're on, start at 2.5 milligrams PO twice a day and figure out where to go from there. And what's the second thing you think I tell them? EKG. And what's the third thing? Don't titrate the drug more than every 7 days. Okay? And I tell you what, for neuropathic pain or mixed pain syndromes, this drug is a savior for a lot of people. It works really, really well. You have a lot of cowboys out there who don't know what they're doing with it. Let's talk about the pharmacokinetics of this bad boy. Basically, it's a racemic mixture of R and S methadone. Here's the easy way to remember this. R methadone stands for relief, right? You get relief from the R methadone. The S methadone stands for sucky. S methadone is responsible for all the bad crap that happens with this drug, particularly the EKG problems. So not to get like all Worthington on you again, but it is metabolized by 2B as in boy 6 CYP system that not a lot of people have heard of before. And there's only 2 pharmacogenomic monitoring companies that actually even offer that. But poor metabolizers of 2B6 are more prone to EKG abnormalities with methadone. Not many of you will see levorphanol. I think there's maybe 2 or 3 of you in here that have taken care of patients that are on levorphanol. To my knowledge, there's one guy in Chicago and myself that are the only 2 people that use this drug in the state. It's basically like methadone light. So it's got all the good stuff of methadone, but it doesn't have any of the EKG problems that methadone does. The problem is it's ungodly expensive. Okay, but it has the same increasing potency that you see with methadone. The reason I put this slide up here is because I just want you guys to have heard of it, because it is available commercially and you may see a prescription or a request for it. Excuse me. Anyone see tramadol? Hey, no addictive potential whatsoever. That's what we were taught when it came out. The guy who made that push to the FDA, his name's Ted Cicero. He's a professor of psychiatry at WashU. He is the one who did all of the company lobbying to the FDA on behalf of McNeil. The reason I know this, I used to work for the drug company that made tramadol, so there's some disclosure there of conflict of interest. Tramadol is absolutely addictive. It is absolutely abusable. And I would submit to you that in actuality, it's worse than a normal hydrocodone morphine to come off of, because not only is it a mu opioid, remember our mu over here, euphoria, respiratory depression, our mu, but it also is a serotonin reuptake inhibitor. Okay, so what winds up happening is if you come off cold turkey from tramadol, not only do you get acute opioid withdrawal, you get serotonin withdrawal syndrome. Have you guys heard about that in this class? Yuck, folks, yuck. You talk about feeling gross, all right? Tramadol is an opioid. There is a preceptor of ours on APPs. If I find out who it is, I'm going to punch him in the throat. that keeps telling students that tramadol is not an opioid, it's an NSAID. Tramadol is not an NSAID, it is an opioid. If you guys get that preceptor on rotation, just look at it and be like, say what? All right. Now, it says norepinephrine serotonin up here. It's primarily serotonin. So should you worry about serotonin syndrome with this drug? Yes, you should. Can you use it with a SSRI? It depends on what the dose is. Should you use it with 3 serotonin active drugs? That's my chicken point where I'm like, yeah, we probably should wrap it up. That's probably too much. The max dose is 400 a day. For the long-acting tramadol, it's 300 a day. We do use some long-acting tramadol, and it does seem to work fairly well, especially for our patients who are somewhere between NSAID and low-dose hydrocodone for OA pain or something along those lines. The other big piece of this, remember codeine? What's the deal with codeine? Prodrug, right? No analgesic activity of the parent drug whatsoever. It had to be metabolized. Guess what? Same thing with tramadol. So one thing that we didn't talk about, right? So 15% of you all, I give you tramadol and it'd be like giving you a Flintstone vitamin, right? Nothing. But what about that 5% of you who are rapid metabolizers of 2D6? Did Dr. Worthington talk about that phenotype? I bet he did. And what do you think happens if you rapidly metabolize codeine or tramadol? Supratherapeutic, right? So you're getting too much. And so it's kind of interesting that I have about 5, maybe 10% of patients that we expose to tramadol that really like it, really like it. And I wonder if we did a genotyping on them, if they'd be 2D6 rapids. I wonder sometimes. All right, what else do we need to know about tramadol? Seizures, guys. Don't forget about seizure disorder. I've actually caused seizures in 2 patients with this drug. Scary, and you feel awful. The patients feel bad, but you feel awful for causing it. Okay? Let's talk about the new kid on the tapentadol or Nucynta. Tapentadol is not tramadol. I hear that from some of the preceptors too. It's the same thing as tramadol. Boy, it is not. It is much more potent than tramadol is. It comes in an immediate release and an extended release, just like tramadol does. The big difference, besides its potency, is that it is more of a norepinephrine reuptake inhibitor than it is a serotonin reuptake inhibitor. So when you think of tramadol, you're thinking serotonin and opioid. When you're thinking of tapentadol or Nucynta, you're thinking opioid and norepinephrine. Okay? Sorry, I'm getting tired. Now, it is FDA approved for diabetic peripheral neuropathy. And this was really surprising to a lot of us that they did this, but it is exquisitely effective for neuropathic pain syndromes. Is it abusable? Yes. Does it have an abuse liability? Yes. Is there a diversion risk? Yes, there is. Okay? And it is C2. Doing all right? Okay. Buprenorphine is a drug that you guys will talk about quite a bit in Dr. Lep's class. For those of you taking the addiction elective, remember this is a partial mu drug. So we just kind of tickle the receptor over here. I'm not going to tickle, but you catch my drift, right? The big thing with buprenorphine is that its binding affinity for the mu opioid receptor is leaps and bounds above most of the other opioids. And so what winds up happening is that if you have somebody who's on another opioid and you expose them to buprenorphine, it'll kick the other drug right off. Okay? The flip side of that is if you're on buprenorphine, because remember, you can get it either as Suboxone, Subzolve, Butrans patch, or something called Subutex, either for addiction or for pain, is that if you need opioid for pain, if you have a car accident or you break your leg in a million pieces or whatever, okay, it is ultra difficult to get analgesic benefit from one of the other mu opioid drugs if buprenorphine is on board and holding on to the receptor. Because, man, once it gets in there, it will not let go. Anybody seeing Butrans go out? Gang, I'm liking that drug. I've had some pretty good luck with it, and especially patients where I'm just not comfortable with the up and down of IR opioids. Here's how you dose the patch. Because it can cause acute opioid withdrawal, they recommend that you wean patients down to no more than 30 milligrams of morphine equivalents a day and then initiate. If you're on more than 80 a day, they don't recommend the patch. So this is really for moderate opioid dose patients. Now, for Suboxone, anyone in here dispensing Suboxone? You need a special Class X DEA, what's called a DATA waiver. So you have to go through special training and get a new DEA number in order to prescribe Suboxone for addiction. You do not need that for this drug, for the buprenorphine patch. And in fact, you don't need the DATA waiver or the Class X DEA to prescribe Suboxone for pain, only for addiction. But most of you all's computers are set up where if you put in Suboxone, it wants that number and won't let you proceed. Okay? Now, bufene is a drug that you will not see unless you work in a hospital. This is, remember, a mixed agonist-antagonist, so it stimulates kappa, which means dysphoria, psychosis, and analgesia, but it blocks mu. This drug is mostly used in labor and delivery. Let me throw an interesting tidbit in. Men express mu opioid receptors much more readily than do women. Women express kappa opioid receptors much more readily than men. Crazy that there might be gender-specific differences in pharmacodynamics of these drugs. And that has been shown in studies with this nalbuphine, where it works really good for women with acute pain and works really bad for men with acute pain. How crazy is that? Does that blow you guys' mind? A little bit? Mind's blown? Okay. Butorphanol is pretty much just like nalbuphine, same deal, kappa agonist, mu antagonist, partial antagonist. Nasal spray and parenteral. Again, butorphanol is used very frequently in perinatal care and in migraines, unfortunately. Okay, so this is not something that I want you guys to memorize. This is more one of those deals where you know where to find it if you need it quickly. But this is the metabolic pathways of all of these drugs, okay? And whether or not they have active parents or inactive pro-drug parents, all right? I tell you what I would put at the bottom of this if I were you, codeine and tramadol, pro-drugs. The rest of these drugs, they can handle their own. Opioids have a lot of adverse effects. We probably don't need to even talk about most of these. They're probably intuitive. They cause drowsiness. They cause constipation. They cause euphoria. They can cause dysphoria. They cause urinary retention. They can be addictive. Okay? There's other stuff that we don't frequently talk about. Opioids can cause really bad pruritus or itching. That is not an allergic reaction. That is a side effect of the drug. It is not an allergic reaction. The other thing opioids can do is they can affect your immune system. So you can see decreases in CD4 and CD8 counts. And it can also affect gonadotropins. So you can see decreases in FSH, LH, and testosterone. So like I just said, you can see decreases in the sex hormones. The symptoms are just like what you would expect for low testosterone. It can cause amenorrhea in women, and it can cause infertility in both women and men with long-term use. Not forever. I mean, you can get your, I don't know what that's called. You can get your fertility back, regrown, whatever, but you know what I'm saying, okay? Opioids can also cause hyperalgesia. Remember, hyperalgesia is when the pain gets worse. So when you use high-dose opioids, you can actually change the characteristics of the pain. That is not tolerance. Tolerance is when you need more drug to get the same effect, so the pain would get better. Hyperalgesia is you give more drug and the pain changes characteristics or gets worse. And then what winds up happening is all these people are taking high-dose opioids thinking that they're treating whatever the underlying pain condition was. And in fact, the pain drug is actually contributing to the pain experience. And not enough people know about that. I talk about opioid-induced hyperalgesia with every single patient that comes into my practice. And the reason I do that is I don't want them thinking that this is a free ride and that there's no downside to these drugs, okay? And so if they really want to feel better, I want them to know that feeling better may not be going up on the dose, it may be going down on the dose. And not to brag, but we've been able to get a lot of people down, way down on their opioid doses in the last couple of years by just sitting and talking to them about this. Now, opioids cause respiratory depression. All right, and that is something you grow tolerant to. So we have patients that are coming in on 30 milligrams of morphine 3 times a day. For those of us that aren't on this drug routinely, that can be a lot, okay, and they get tolerant to that. Where people are getting hurt is that opioids blunt the response to pH and CO2 changes that cause us to breathe while we are asleep. And so if you are already predisposed to respiratory depression or what we call sleep disordered breathing, like obstructive sleep apnea or central sleep apnea, or you're on a drug like a benzodiazepine or an Ambien or one of those, it increases your risk for not breathing while you are sleeping. Yes, ma'am. Interesting question. She said, what if they're on a CPAP? The common thought is, oh, they're on a CPAP, it's all good. But the answer is CPAPs do not protect against opioid-induced sleep disordered breathing. It has to be a BiPAP because CPAPs only are good for obstructive sleep apnea. What opioids are causing is a central sleep apnea. There's no drive to breathe. Got the morphine equivalent. And the little thing going up are central sleep apneic episodes on polysomnography. The take home on this means that the higher the dose you're on, the less you're breathing at night. Last time I checked, breathing was like good, right? Not breathing was bad. So let's talk about equal analgesic conversions. So basically what we're looking at, where am I at slide-wise? Hey, we're not, I can't believe we're actually doing this. All right. This table, which I will give you on any exam that I have regarding opioids, is very intuitive, okay? So for instance, my patient that was on 30 milligrams 3 times a day of oral morphine, right? How much IV morphine is that equal to based on this chart? I'm sorry? 30 of IV, right? If I have a patient that's on getting 30 milligrams of oral morphine a day, how much oxycodone is that equal to? Oral morphine to oral oxycodone. What's my daily oxycodone dose? 20. It's just, I mean, it's just, you just put your finger on the chart and you move it down, right? Easy. So you can use this chart to convert between any of these opioids. Here are the caveats, okay? This is not a perfect tool. This is not a perfect tool. And it is much harder to take back too much opioid than it is to be conservative and increase it. Does that make sense clinically? Like clinical common sense. It's easier for me to go, I undershot, I'll give you a little bit more, than, oh crap, I gave you way too much and now I got to give you naloxone. Okay? So what we generally say is if you're going to convert between two different drugs, that you reduce the target drug dose by 30%. So let's go back to our morphine discussion. So I have morphine, it's 30 milligrams a day, okay? 30 a day of oral morphine, and I want to go to oral oxycodone. So you guys already told me that it's 20 milligrams of oral oxycodone, did you not? Now I need to reduce that just to be safe, because this isn't a perfect tool. So 30% reduction of 20 milligrams of oxycodone then becomes approximately what? I'm sorry? 14? Everybody agree with that? Oxycodone comes in a 15 milligram tablet, so we're pretty close. Does this make sense? Does this make sense what I'm saying? Okay. Now, what if I go from my 30 milligrams of oral morphine to IV morphine? And what did you guys tell me that would be? 10 of IV morphine. Do I need to reduce it for cross tolerance? No, I'm going to the same drug. It's just a different delivery method. We got it? Are we good? All right. In your, we got 5 minutes left. We made it to where I want to, what do we got? Scroll down, would you? Crap. All right, I'm 5 off. That's all right, we can make up time Monday. So what I want you guys to do is open that document in Blackboard, the practice one. Let's spend the next 5 minutes just playing around with these, okay? I'll make a deal with you. You guys pull it up on your screen, and I will pull up the chart. These questions will be very familiar to you. One other thing we're going to cover on Monday as far as cancer pain is concerned, but you know, if you guys want to practice on these later. So I talked to you about reducing the target dose by 30%, right? The next piece that I want to make sure that you guys know is that if you are treating a patient, especially for like cancer pain, and they're on long-acting drug, and you need to give them a breakthrough immediate release dose, let's go back to our 30 milligram 3 times a day example. So I'm on 30 milligrams of MS Contin 3 times a day, and I want to give a patient something for breakthrough pain. The rule of thumb is that each breakthrough dose should be 10% of the total daily dose. Each breakthrough dose should be 10% of the total daily dose. So my example of 30 milligrams 3 times a day, which equals 90 milligrams of morphine per day, each breakthrough dose should be 9 milligrams. Okay? Okay, see if you can get a couple of these done before we head out. Okay. Okay.